Okay, let's unpack this. Imagine, just for a second, this sudden, really sharp pain, like totally out of the blue, nothing you felt before.
Yeah, it's a scary thought.
Exactly. And that's where we're going today. We're doing a deep dive into a condition that can hit just like that. Aortic dissection.
A critical one.
Totally. And this is for you if you're listening and you want to get a quick, solid grasp of a serious medical emergency. We've gone through the detailed notes.
Yeah, lots of material.
To pull out the essentials. What it is, why it happens, the signs, the treatments. Basically, all the key stuff distilled down.
Let's get into it then. So, aortic dissection. What are we actually talking about?
Good starting point.
At its core, it's a tear. A rip in the inner lining of the aorta. That's the big artery coming right off the heart.
The main pipeline.
Precisely. And when that inner layer tears, blood under high pressure can actually surge through the tear.
Whoa!
Yeah, it pushes between the layers of the artery wall, separating them and creating, well, a new channel for blood flow. We call it a false lumen.
A false lumen. Huh. So the blood isn't staying in the main pipe anymore. It's sort of forcing its way into the wall itself.
That's exactly it. And you can imagine, that's not good.
No. Sounds like it could really mess up blood flow to, well, everywhere else.
It absolutely can. It disrupts blood getting to vital organs. That's the major danger. Now, we also talk about timing.
Right, like how long it's been going on.
Yeah. Acute means it's happened within the last 14 days. Subacute is 15 to 90 days. And chronic is anything over 90 days.
Okay, that makes sense. Now, classifications. I always hear about Stanford Type A and B, and then DeBakey types as well. Can you break those down?
Sure. They're crucial because they tell us where the dissection is, and that really guides the treatment. The Stanford system is, well, maybe a bit simpler day to day.
Okay.
It just asks, is the ascending aorta involved? That's the part rising up from the heart. If yes, it's type A.
A for ascending. Sort of.
You could think of it like that, or just A is higher up. Type A is about 2/3 of cases, so it's more common.
And type B?
Type B means the tear starts after the main branches to the arms and head, specifically distal to the left subclavian artery. So it's in the descending aorta. That's the other third.
Got it. A is ascending involvement. B is descending only. How does DeBakey fit in? Is it just more detail?
Exactly. DeBakey gives a more anatomical map. Type I starts in the ascending aorta but extends further, usually into the arch and maybe down the descending aorta too.
It was extensive.
Very. DeBakey type 2 is only in the ascending aorta. It stops before the arch.
Okay.
And type 3 starts in the descending aorta, like Stanford B, and goes downwards. Memory tip. DeBakey numbers sort of follow the extent of the dissection away from the heart.
Right. I like those memory aids. So we have this tear, this false channel. What actually causes the aorta wall to tear in the first place? What's the underlying issue?
The fundamental problem is usually a weakening, a kind of degeneration in the middle layer of the aortic wall, the tunica media.
So the wall itself is becoming less strong.
Yeah, it loses its structural integrity, its resilience. Think of the collagen and elastin fibers breaking down.
Makes sense. And what makes it weak like that?
Well, the biggest factor, far and away, is high blood pressure. Chronic hypertension puts immense stress on the aortic wall.
Okay, hypertension is key. What else?
Certain genetic conditions are important connective tissue disorders. You've probably heard of Marfan syndrome.
Yes.
And Ehlers-Danlos syndrome. These affect the body's collagen and elastin, the very building blocks of the aorta. So the aorta is inherently weaker.
Ah, okay. That connection is interesting.
Then there's trauma, like a major blow to the chest, maybe in a car crash.
Right.
And also pre-existing problems with the aorta itself, like aortic valve disease or something called coarctation, which is a narrowing of the aorta.
Okay, so a range of things can weaken that wall.
Yeah.
Who is actually most likely to get an aortic dissection? What are the main risk factors?
As we said, hypertension is number one. It's present in like 50 to 70% of cases, maybe even more.
Wow, that's high.
It is. Older age is another factor, usually over 60, and it's more common in men than women. Then we have those connective tissue disorders again, Marfan's, Ehlers-Danlos. Having a bicuspid aortic valve is another one.
Instead of the normal 3 leaflets.
Exactly. That puts different stresses on the aorta. Also, previous aortic surgery or interventions, major chest trauma we mentioned, Pregnancy can be a risk factor.
Really? Pregnancy?
Yes, the hormonal and hemodynamic changes can play a role, though it's rare. Other things include certain infections like syphilis historically, some genetic syndromes like Turner's or Noonan,
Okay.
and lifestyle factors like smoking, high cholesterol, and even intravenous drug use.
Yeah.
And definitely family history if relatives have had aneurysms or dissections.
That's quite a list. So let's trace the pathophysiology again, the intimity cares.
Right, that innermost layer, the tunica intima, gets a tear. Then the high-pressure blood flow from the heart finds that tear, and it just forces its way into the middle layer, the media. It starts splitting the layers apart.
Creating the false lumen.
Creating the false lumen, exactly. It dissects along the length of the aorta, sometimes for a short distance, sometimes much further. And the big problem, pathologically, is how this affects blood flow.
In both channels.
Yeah, the blood flow in the original true lumen can be compressed or blocked, and the flow into the false lumen might steal blood supply or rupture outward. That's like a river suddenly splitting, and one channel might get way less water, starving whatever relies on it downstream.
That imminent really helps. Okay, so someone comes in maybe with that tearing pain. What else could be going on? What's the differential diagnosis?
That's super important because misdiagnosis can be catastrophic. Top of the list, cardiovascular stuff. A heart attack, myocardial infarction.
Okay, how do you tell the difference?
It can be tough. Dissection pain is often described as maximal at onset, sharp tearing, maybe radiating to the back. Heart attack pain is often more crushing, pressure-like, maybe building up, but there's overlap.
Right. What else cardiovascular?
An aortic aneurysm that hasn't dissected yet, maybe aortic regurgitation, a leaky valve causing symptoms, or pericarditis inflammation around the heart.
And outside the heart.
Lung problems are big differentials. A pulmonary embolism, a clot in the lungs can cause sudden chest pain and shortness of breath. Pneumothorax, a collapsed lung, pleuritis, inflammation of the lung lining. And then other things too, like severe musculoskeletal pain, maybe a tumor in the chest, gallbladder issues, even cholesterol emboli breaking off.
So you really have to keep a broad perspective initially. How common is this condition, actually? You hear about it, but...
It's generally considered rare. In the UK, the numbers are maybe around 2 to 3 cases per 100,000 people per year.
So not common, but definitely high stakes when it does happen.
Let's talk presentation. What are the classic symptoms someone might experience?
The absolute classic is that sudden, severe chest pain, often described as sharp, tearing, or ripping. It's frequently felt radiating through the back, especially between the shoulder blades. That's particularly common in Type A dissections. That tearing description is quite vivid.
It really is. Other symptoms can include things that mimic other problems like angina pain, sudden weakness or paralysis in the legs, paraplegia if the spinal arteries are affected.
Wow.
Neurological symptoms like stroke if the dissection affects the carotid arteries. Fainting or syncope is also quite common. Some people describe 2 phases. The initial intense tear, then maybe a phase where pressure builds before a potential rupture.
That sounds terrifying. What signs might a clinician pick up on examination?
Well, a key one is looking for pulse differences. Is the pulse weak or absent in one arm compared to the other? Or in the neck, carotid, or leg femoral arteries?
Pulse deficit.
Exactly. Listening to the heart, you might hear a new murmur of aortic regurgitation if the dissection has damaged the aortic valve. And checking blood pressure in both arms is crucial.
Why both?
Because a significant difference, usually we say more than 20 millimillars G systolic difference between the arms, is a very suggestive sign. Exam tip. Always do bilateral arm BPs.
Good tip. Anything else?
Well, while hypertension is a risk factor, the patient might actually have low blood pressure if they're in shock, say from rupture or tamponade. Limb ischemia, a cold, pale, painful limb, can occur if the dissection blocks flow. And the ECG.
What about the ECG? Does it show the dissection?
Usually no. The ECG is often nonspecific or might just show some general strain patterns, but it's vital to do one immediately to help rule out a standard heart attack, MI. You definitely don't want to give clot busters for an MI if it's actually a dissection.
Right, that could be disastrous. So the history and exam raise suspicion. How do you confirm the diagnosis?
Imaging is king here. You need to see the aorta.
Okay.
A chest x-ray might be done first, and it could show a widened mediastinum, that space in the middle of the chest, which is suggestive, but it's often normal, not definitive at all.
So what is definitive?
For a stable patient, the gold standard is usually a CT angiogram, a CTA scan. It uses contrast dye and gives really detailed pictures of the aorta showing the tear, the false lumen, the extent. MRI, or MRA, magnetic resonance angiography, is also excellent, very sensitive and specific, but maybe less readily available acutely or takes longer.
And echocardiography, ultrasound of the heart.
Yes, that's very useful too. Transthoracic echo, the probe on the chest wall, can sometimes see the proximal aorta and check for complications like aortic regurgitation or fluid around the heart, tamponade. Transesophageal echo, or TE, where the probe goes down the esophagus.
Like right behind the heart.
Exactly. It gives fantastic views of the aorta, especially the thoracic aorta. Very useful, particularly if the patient is too unstable for CT or maybe at the bedside or in the operating room.
And blood tests. Do they help diagnose it?
They're important for assessing the patient overall, checking blood count, kidney function, clotting, cardiac enzymes to help rule out MI, but they don't diagnose the dissection itself. The diagnosis relies on that visualization with imaging.
Okay, diagnosis confirmed. This is an emergency. What happens next? What's the immediate management?
Absolutely an emergency. Priority 1 is getting the patient to a specialist center with cardiac surgery capabilities. Urgently.
Okay, and en route or on arrival?
Stabilization. Aggressive blood pressure control is key. We use intravenous medications, often beta blockers first, like labetalol or esmolol, to lower the heart rate and the force of contraction.
Reduce the stress on the aorta wall.
Precisely. And then often add vasodilators, like sodium nitroprusside, if needed, to bring the systolic blood pressure down rapidly. The target is usually quite low, maybe 100 to 120 millimilli-Gg systolic.
Wow, that's quite tight control.
It has to be, to limit the dissection propagating or rupturing. Pain control is also vital, usually with intravenous morphine. And general measures, 5E access, oxygen, continuous monitoring, getting them to that specialist unit fast.
Okay, so stabilize, lower BP, manage pain, transfer. What about the definitive fix? Is it always surgery?
It depends crucially on the type. For Stanford Type A, involving the ascending aorta,
The ones closer to the heart?
yes, surgery is almost always the answer, and it's usually urgent. The risk of fatal complications like rupture into the pericardium, tamponade, or coronary artery involvement is just too high otherwise.
And the surgery involves?
Typically replacing the damaged section of the ascending aorta with a synthetic graft. Sometimes the aortic valve needs repair or replacement too. It's major surgery.
I can imagine. What about Type B? The descending aorta dissections.
For uncomplicated Type B, the initial approach is often medical management.
So just the blood pressure control and monitoring.
Strict blood pressure control, yes, pain relief, and often bed rest initially, with close observation and repeat imaging. Many uncomplicated Type B dissections can stabilize and heal, to an extent, with medical therapy alone.
But not always. When would Type B need intervention?
Intervention is needed if complications develop. Things like persistent pain despite medication, signs the dissection is expanding, rupture or impending rupture, or malperfusion, reduced blood flow to organs like the kidneys, gut, or legs.
And what kind of intervention for Type B?
Increasingly, it's endovascular repair. TVAR, thoracic endovascular aortic repair.
Stent grafts.
Exactly. They insert a covered stent graft via catheters, usually from the groin, to cover the entry tear and redirect blood flow into the true lumen, basically sealing off the false lumen. It's less invasive than open surgery.
Does TVAR work well?
It's shown good results, especially for complicated Type B, often better short-term outcomes than open surgery. Open surgical repair is still an option if TVAR isn't suitable for anatomical reasons.
What about chronic dissections, ones found later?
For stable, chronic Type B dissections, it's often continued medical therapy and regular surveillance imaging to watch for aneurysm formation. Surgery or TVAR might be needed if it progresses or becomes symptomatic later on.
This sounds incredibly serious.
Yeah.
What's the outlook, the prognosis for someone with an aortic dissection?
It's highly variable, but yeah, it's very serious. The key factors are really the location. Type A is generally more immediately dangerous, and how quickly treatment is started.
Time is critical.
Absolutely. Without treatment, mortality for Type A dissection climbs rapidly, like 1–2% per hour in the first day or two. Aortic rupture itself has a terrifyingly high mortality rate, maybe 80%.
So getting diagnosed and treated fast is life-saving.
Definitely. Early intervention, whether medical or surgical, dramatically improves survival. But even with treatment, there are risks. Major surgery carries operative mortality, and even after successful repair, long-term monitoring is needed. Late deaths can still occur, often from rupture of other parts of the aorta or related complications.
So follow-up is lifelong.
Pretty much, especially blood pressure control. For stable Type B managed medically, there's a long-term risk of the dissected segment enlarging into an aneurysm over time, so regular scans are essential.
Given the severity, can anything be done to prevent it, especially in those high-risk groups?
Prevention really focuses on managing the known risk factors for those with inherited conditions like Marfan's or Ehlers-Danlos.
The connective tissue disorders.
Right. Lifelong beta blockers are often recommended to reduce aortic stress. Regular screening with echocardiograms or CT-MRI to measure the aortic diameter is crucial.
And if it gets too big?
Then prophylactic surgery replacing the aortic root or ascending aorta before it dissects or ruptures might be considered if it reaches a certain size threshold.
What about for the general population?
Aggressive blood pressure control is the most important thing. Lifestyle stuff too, quitting smoking, managing cholesterol, and maybe activity restrictions for certain high-risk individuals, like avoiding intense weightlifting.
Okay, finally, let's talk complications. What can go wrong as a direct result of the dissection itself?
Lots of things, unfortunately, depending on where the tear goes. If it tears backwards towards the heart,
Problems there.
yes, it can damage the aortic valve, causing severe aortic regurgitation. It can even dissect into the coronary arteries, causing a heart attack, often an inferior pattern MI, or rupture into the pericardial sac, causing cardiac tamponade fluid compressing the heart.
Life-threatening stuff. And if it tears forwards, down the aorta.
Then it can compromise blood flow to almost anywhere. Blocking the arteries to the arms leads to those unequal pulses, or BP. Blocking the carotids causes stroke, renal arteries kidney failure, spinal arteries paraplegia, gut arteries mesenteric ischemia, leg arteries limb ischemia.
It really can affect the whole body systemically.
It absolutely can. Organ malperfusion is a major complication. Aortic rupture, as we said, is often fatal, and over time, the weakened dissected aorta can dilate and form an aneurysm.
Any other complications to mention?
Hypotension, low blood pressure is usually a very bad sign.
Yeah.
That new aortic diastolic murmur from regurgitation, heart failure, syncope, the fainting spells. Rarely superior vena cava obstruction if the dissection compresses that major vein.
Okay, that covers a lot of ground. So just to recap the absolute key points for everyone listening.
Yeah, the take-homes.
Aortic dissection. It's a tear in the aorta's inner lining. Creates a false lumen. Presents often with sudden, severe tearing chest or back pain.
Critical point. It's a medical emergency. Type A, ascending, usually needs urgent surgery. Type B, descending, often starts with medical management, but might need intervention.
Diagnosis relies heavily on imaging. CT, angio is often the go-to, and management focuses on rapid BP control and transfer to a specialist center.
And remember those risk factors. Hypertension is huge, plus connective tissue disorders, age, male gender, bicuspid valve. Knowing these helps with suspicion.
Absolutely. Understanding these features is so important, right? It helps appreciate just how complex and urgent these cardiovascular emergencies can be.
Definitely. It really underscores the need for prompt recognition and action.
This whole deep dive, it really highlights how one event inside a major blood vessel can just ripple outwards with potentially devastating effects across the whole body. It makes you wonder what other conditions might be lurking, seemingly silently, with that kind of dramatic potential.
That's a great thought to leave people with. And of course, for anyone revising this topic, maybe for exams like the MSRA, you can find more resources and practice questions to really nail this down over at pastthemsra.com and freemsra.com.
Excellent resources. Definitely check those out.